Welcome to the deep dive. Today, we are taking on a deep, dense, and frankly, a life or death topic: neonatal surgery.
It really is. This is a field that's just defined by technical precision on one hand and extreme patient fragility on the other.
Absolutely. And our source material for this is the authoritative Chapter 18 from the 28th edition of Baily and Love.
That's right. And for anyone studying or practicing, this chapter is, it's incredibly high yield, but it can feel overwhelming.
I can see that.
Yeah, because it introduces a completely different set of physiological rules compared to adult or even general pediatric surgery.
So our mission here is really clear then. We are interpreting and analyzing this chapter for you.
Exactly. Think of this as a structured ready reckoner. We're building context, we're building memory anchors to help this stuff stick.
But, and this is a crucial disclaimer, it is absolutely not a substitute for reading the source material.
Not at all. You still need to read the book. But we're here to make sure the core concepts, they really land instantly.
Exactly. We're providing a mental framework, the aha moments, and the clinical rationale that ties all the facts together. So to start, what exactly defines the surgical neonate? What are these specialists actually managing?
Well, neonatal surgeons are specialized pediatric surgeons. And their domain really encompasses two major categories of pathology.
Okay.
First, you have the management of life-threatening, non-cardiac structural congenital anomalies. So these are the defects that are present from birth.
And the second category?
The second is the management of one major acquired condition that primarily attacks premature infants, necrotizing enterocolitis, or NEC.
Got it. So our journey has to start at the very beginning then, with the etiology of congenital anomalies. If we're dealing with all these structural defects, we have to understand why they happen.
Right. And the source material outlines 5 major etiological classes that underlie these structural failures.
Okay, let's break those down.
So we can sort of categorize the causes based on when the insult happens and what type of factor it is. The first class is pretty straightforward. Gene defects. Specific mutations that just cause development to go awry.
Simple enough. What's number 2?
Number 2 is aneuploidies. These are whole chromosome abnormalities. So think trisomy 21, for example.
Okay, and third?
Third, we have infections that are contracted in utero. The classic examples here are the Torchy infections, toxoplasmosis, cytomegalovirus, and rubella.
Right. The fourth class then moves to external agents.
Precisely, the teratogens. So these are external agents like certain drugs, heavy alcohol consumption, or smoking during pregnancy that interfere with normal development.
And the fifth one, this one feels a bit different, late mechanical etiologies.
It is different, and this is a really key interpretive point. The first 4 are about an intrinsic failure in the blueprint. This 5th category suggests that development was initially fine.
But something happened later in the pregnancy to cause the damage.
Exactly. It's not a failure of initial cell assignment. It's a secondary damage event. And the textbook gives 2 excellent examples of this.
What are they?
First is the segmental ileal volvulus that you can see with thick, impacted meconium and cystic fibrosis. The bowel literally twists on itself and compromises its own blood supply.
Okay, so a mechanical blockage causing a vascular problem.
Right. And the other classic example is the lung hypoplasia you see in a congenital diaphragmatic hernia. The physical presence of abdominal organs up in the chest just mechanically restricts the growth of the lung tissue. So this category is all about insult, not intrinsic failure.
This is where it gets really fascinating for me. The underlying mechanism, the power of gastrulation insults.
Yes. Gastrulation is this absolutely critical period very early on when cells are basically deciding their future, where they're going to go, what they're going to become.
And if you disrupt that process.
If you disrupt that process, the resulting defects are systemic and often geographically miles apart in the body. That early timing, usually weeks 3 to 8, explains why one single event can result in multiple, seemingly unrelated anomalies.
A field defect.
It's a field defect, and we see this so clearly in 2 complex syndromes that are just massive red flags for any clinician.
Let's start with the first one, Vactorel syndrome. Can you unpack that acronym for us? Because the sheer breadth of it is staggering.
It really is. Vactorel is an association, not a single disease. It requires anomalies in 3 or more of the following systems: vertebral,
Okay.
anorectal, cardiac, tracheoesophageal, so your O2 fits in here, renal, and limb defects.
So the spine, the GI tract, the heart, the limbs, it's everything.
The insult happened so early that the blueprint for all those systems was corrupted at the same time.
And the second equally serious association is charge syndrome.
Charge is another profound multisystem defect. You have coloboma, which is a keyhole defect in the eye.
Right.
Heart defects, atresia of the choanine, the passages from the nose to the throat, retardation of growth, genital anomalies, and ear anomalies or deafness. Again, you just look at that list and you realize the scope of that early failure.
So the clinical implication here is paramount, and the source really stresses this. If you find one anomaly, what do you have to assume?
You have to assume there are siblings, associated anomalies lurking just beneath the surface.
So screening is mandatory.
It's compulsory. If a neonate is diagnosed with one structural anomaly, you need a careful physical exam, advanced imaging, and often genetic screening. The text gives that classic high-yield example. Duodenal atresia has a significant association with trisomy 21.
So you find the duodenal obstruction, you're immediately screening for Down syndrome.
And other defects, especially cardiac ones. Screening isn't just good practice. It's a necessary safeguard against missing other life-threatening conditions.
That structural foundation really sets the stage for where the surgery happens. We are moving now into Section 1, Newborn Physiology and Surgical Principles. We've established that a newborn is not just a tiny adult. It is a patient defined by immaturity and, frankly, volatility. I think the House of Cards analogy is just perfect here.
It really is. The idea that failure in one system causes this rapid cascading collapse in all the others.
Exactly.
And that analogy just perfectly captures the physiological constraints that are summarized in the source materials table 18.2. Every single system, airway, respiratory, cardiovascular, fluid, thermal, is underdeveloped.
Which means the surgical management has to be
Precise, fast, and constantly focused on supporting all of these unstable systems at the same time.
Okay, so let's unpack the specifics, starting at the very top, literally, with the airway challenges. Why is intubating a neonate so notoriously difficult?
Right. And it really comes down to the anatomy. The anatomy itself almost seems to conspire against you.
How so?
Well, for one, you've got a relatively large occiput at the back of the head. So when a neonate is just lying flat, that naturally forces their neck into a flexed position.
Okay, so you're already starting at a disadvantage.
Exactly. And then you add in a disproportionately large tongue and a high, sort of C-shaped and very angled epiglottis.
So all of that together means your standard adult approach is just, it's not going to work.
Not at all. It demands a totally different toolkit. You have to use a straight laryngoscope blade, not a curved one, so you can physically lift that floppy epiglottis out of the way. You need an uncuffed tube, and you have to deliberately place the head in what we call a neutral sniffing position.
Maybe with a shoulder roll or something to help.
Precisely. You often need a shoulder roll just to counteract that natural flexion from the big occiput. It's a whole procedure before the procedure even starts.
Okay, moving down to respiratory vulnerability. This is largely defined by prematurity, I imagine.
Yes. The underlying issue is often a deficit of pulmonary surfactant, whether that's due to prematurity or other factors like gestational diabetes or birth asphyxia.
And low surfactant is just catastrophic for the lungs.
It is. It reduces lung volume, it decreases compliance, so how easily the lung stretches, and it makes the air sacs, the alveoli, collapse during expiration. We call that atelectasis.
And I'm guessing their muscular reserve is equally limited.
That's right. Their respiratory muscles, especially the diaphragm, are primarily made of fast-twitch type 2 fibers, not the fatigue-resistant type 1 fibers you see in adults.
So they just get tired much, much faster.
Much faster. And if you combine that muscular vulnerability with the need for prolonged ventilation, high airway pressures, high oxygen, you risk developing chronic lung disease and scarring.
So management is a very delicate balancing act.
A very delicate act. You've got surfactant replacement using CPAP to keep the airways open, or mechanical ventilation using the absolute lowest pressures and oxygen you can get away with.
If the respiratory system is compromised, the cardiovascular immaturity is the next domino to fall.
Absolutely. The critical event here is the transition from fetal circulation to postnatal circulation.
Explain that.
In the fetus, pulmonary pressures are very high, and that shunts blood away from the lungs. After birth, that pulmonary vascular resistance, or PVR, should fall dramatically.
But if the baby is stressed?
If the baby is stressed, so hypoxic, acidotic, or has high PCO2, the PVR can spike right back up again very quickly.
And what happens if those fetal shunts, like the ductus arteriosus, are still open when the PVR spikes?
That's the trap. If the ductus arteriosus or the foramen ovale are patent, that high pressure on the right side of the heart forces blood through those shunts and bypasses the lungs entirely.
A right-to-left shunt.
A right-to-left shunt, and that immediately causes severe hypoxemia, which just perpetuates the cycle of hypoxia and acidosis, driving the PVR even higher. It's a runaway train.
What's the most critical difference in hemodynamic response that distinguishes a neonate from an adult? This seems really key.
It's the underdeveloped baroreflex.
Okay.
In an adult, if you lose blood, the baroreflex triggers a rapid constriction of your vessels and an increase in heart rate to maintain blood pressure.
But in a neonate?
In a neonate, that reflex is immature or completely absent, and the consequence is immediate and terrifying.
Okay.
Unchecked blood loss leads rapidly, often precipitously, to profound hypotension. There's no time for gradual compensation. You lose control almost instantly.
That volatility brings us directly to fluid and electrolyte balance. I mean, the ratio of surface area to body weight alone suggests a huge risk.
They're like heat and fluid sponges in reverse. Their high surface area means they lose both heat and fluid much, much faster.
And their kidneys aren't helping.
Not at all. Their kidneys are immature, they're functionally less efficient, so they end up losing essential elements in the urine: sodium, bicarbonate, glucose, amino acids.
And you couple that with their nutritional status.
Right. They have very low glycogen stores, so any prolonged fasting or the high metabolic demands of stress can lead to hypoglycemia very, very quickly.
What's the specific management anchor for fluid replacement that the source material demands we remember?
Maintenance fluids have to be very carefully formulated. They need 10% glucose to counter those low glycogen stores, plus appropriate electrolyte replacement.
And there's a detail here with huge consequences.
A massive one. You must avoid the combination of hyperglycemia, high glucose, and hypernatremia, high sodium.
Why is that combination so dangerous?
Because that osmotic combination creates fluid shifts in the brain that significantly increase the risk of intraventricular hemorrhage, or IVH, especially in the extremely preterm baby.
So what's the rule for replacing ongoing losses, say from an NG tube?
If the baby has significant ongoing losses, say from a nasogastric tube or a stomaco, any output greater than 15 milliliters TCL day needs to be replaced. Milliliter for milliliter using 0.9% ACL with 0.15% KCL added. You have to be that precise.
Let's tie that fluid loss directly into thermoregulation.
Well, their inability to shiver, combined with that huge surface area for heat loss, means they're utterly reliant on external heat control.
And low temperatures aren't just uncomfortable, they're catastrophic.
They are. Hypothermia promotes coagulopathy, it depresses the function of the heart muscle, and it leads to a worsening metabolic acidosis.
Which then compromises that fragile PVR cycle we just talked about.
Exactly. It's all connected.
So the surgical principle here is completely non-negotiable.
Absolutely non-negotiable. You limit exposure time, you maintain a warm theater, often 28 degrees Celsius or higher, you use warming devices on the table, and you ensure all fluids, including blood, are warmed before they go in.
So with all those constraints in mind, how do they inform the perioperative principles and surgical access?
The overarching principle is efficiency and gentleness. Every single operation must be efficient, using meticulous and gentle tissue handling to minimize inflammation and bleeding.
And you need cover.
Broad-spectrum antibiotics are standard. And because of that rapid decline potential and the fragility of the large neonatal liver, blood products must always be typed, crossed, and available for any major abdominal surgery.
This sounds like an environment where sometimes the most extreme measures are necessary. Let's talk about damage control in this population.
Damage control is a strategy we've borrowed from adult trauma, but it's perfectly adapted for the sick, unstable infant. Think acute midgut volvulus causing ischemia, or a severe perforating necrotizing enterocolitis.
So what does that look like in practice?
The initial operation is often performed right at the cot side in the NICU, not even in the main operating theater. The goal is just rapid source control, removing contamination, and stabilizing the baby.
And the definitive repair comes later.
It's delayed, usually 24 to 48 hours later, via a planned second-look laparotomy, once the baby is metabolically stable.
And what about surgical access? The anatomy must demand some specific incision choices.
It does. We have to navigate that specific neonatal anatomy. For instance, a right-sided transverse muscle-cutting incision is common, but you have to be extremely careful to avoid the large, fragile liver.
And a midline incision.
The midline longitudinal incision has to avoid the bladder, which sits much higher in the pelvis in a neonate. Surgeons might also use muscle-sparing approaches like the supraumbilical or omega incisions. And for a left diaphragmatic hernia, the subcostal approach is standard.
Okay, let's revisit that critical detail about IVH risk and positioning the Trendelenburg warning. This seems incredibly important.
This is a high-stakes, specific precaution for the preterm baby.
Yeah.
The Trendelenburg position, where the head is elevated above the feet.
Right, to shift abdominal contents.
Exactly. But in the preterm infant, this elevation causes fluid shifts and increases central venous pressure. And this can rupture the incredibly fragile germinal matrix vessels in the brain, leading directly to intraventricular hemorrhage.
So it's a hard rule.
It's an absolute rule. When you're placing the diathermy grounding pad or adjusting position, you must avoid any head elevation in the preterm baby.
Wow, that mechanism sounds terrifyingly fragile. Which leads us perfectly to our check-in question for this section.
Let's hear it.
Considering all the physiological constraints we've discussed, specifically that high risk of rapid, unchecked hemodynamic collapse, if a preterm neonate is losing fluid quickly in surgery and suddenly develops profound hypotension after minimal blood loss, what specific cardiovascular reflex is likely absent or severely underdeveloped, contributing to this sudden catastrophic decline?
If you need a moment, rewind and listen to that House of Cards section again. The answer is the bear flex.
Okay, let's move seamlessly from that volatile physiological environment to the specific structural defects of the alimentary canal in Section 2. Neonatal gastrointestinal surgery. We have to begin with the most famous communication failure of the GI tract, esophageal atresia and tracheoesophageal fistula.
Yes, this is a fundamental developmental failure, where the trachea and esophagus just fail to fully separate.
Leaving the esophagus divided.
Divided and blind-ended, and often with an abnormal connection to the airway via a fistula.
And the presentation often starts in utero.
It does. If the upper esophagus ends blindly, the fetus can't swallow the amniotic fluid. This classic sign, polyhydramnios or excessive amniotic fluid, is often the very first antenatal clue.
And after birth.
Postnatally, the signs are unmistakable. Excessive drooling, choking, aspiration, or cyanosis immediately upon attempting the first feed.
How do you confirm that diagnosis instantly after birth?
You try to pass a nasogastric tube, and it fails. A chest x-ray will confirm the tube is coiled up in that blind upper esophageal pouch.
So immediate management is all about preventing aspiration.
It is. And this is where the repilagal tube comes in. It's a specialized double lumen catheter. One lumen provides constant, gentle sump suction to remove saliva and prevent it from pooling.
And the other lumen?
The other lumen lets air in, which stops the tube from sucking onto and damaging the pouch wall. This constant drainage is absolutely critical.
The source material details 5 anatomical variations. The distinction here, especially for management, seems to depend on the fistula's location and the gap length.
Yes. The vast majority, about 85%, is type C. That's atresia, with fistula connecting the distal segment of the esophagus to the trachea.
And the others?
Type A is pure atresia with no fistula, and type B is atresia with a proximal fistula. The key feature of both of those is that they have a long gap between the two segments.
And then there's the odd one out, type E.
The isolated H-type fistula. It's unique because there's no atresia. The esophagus is continuous. It just has that abnormal connection to the trachea.
Okay, let's discuss the critical clinical consequence of having a distal fistula, what the book calls the ventilation trap.
This is one of the most critical concepts for surgical planning, especially in a baby who's premature and might need respiratory support for something like RDS.
So what's the trap?
If a baby with a distal fistula type C or E needs positive airway pressure from CPAP or a ventilator, that pressure is driven directly to the fistula and right into the stomach,
Causing massive gastric distension.
life-threatening gastric distension. It elevates the diaphragm, which compromises the already vulnerable lungs, and critically, it risks gastric perforation.
So if pressure support is unavoidable,
You have to perform an emergency fistula ligation immediately to prevent that from happening.
the surgical strategy then hinges on whether you can bridge that gap immediately.
For favorable gaps, usually type C or D, you attempt a primary repair. The approach is usually a right thoracotomy or thoracoscopically. You divide the fistula and then stitch the two esophageal segments together over a transanastomotic tube, which allows for early trickle feeds.
And what about those really challenging long gap anomalies like type A and B?
If the gap is too long for a tension-free anastomosis, you have to stage the repair. Stage 1 involves creating a cervical esophagostomy so saliva can drain out the neck, and a gastrostomy tube for nutrition.
And then you try to bring the ends together over time.
You might try progressive traction sutures to gradually lengthen the ends over weeks. If that fails, or the gap is just too long, Then later esophageal replacement is required, usually using a segment of colon or jejunum.
And what about that elusive, isolated type E fistula?
Because there's no atresia, meconium is passed and the diagnosis is often delayed. These babies present chronically with recurrent chest infections or coughing spells after feeds from constant microaspiration. It's diagnosed with a contrast swallow and usually repaired in the neck.
Moving down the tract, duodenal atresia and small bowel atresias. Let's start with the duodenum.
Duodenal atresia, or DA, is an obstruction of the duodenum, usually just distal to where the bile duct enters. So the proximal duodenum right after the stomach becomes massively dilated with swallowed fluid.
And the radiographic sign is one of the most famous in pediatric surgery.
The double bubble sign. It's the hallmark. One bubble is the gas-filled stomach, and the second is the dilated proximal duodenum. The obstruction stops any air from passing further down.
And if you do see gas distally,
then you have to suspect a more distal obstruction, or maybe an incomplete one, like a web.
the association here links right back to our initial discussion on etiology.
It absolutely does. Duodenal atresia has a very high incidence, up to 30% of being associated with trisomy 21 Down syndrome, which again highlights the need for mandatory genetic and cardiac screening.
And the repair?
The surgical repair is the Kimura duodenodudenostomy. It's a diamond-shaped anastomosis that's designed to create a wide, non-obstructive passage past the point of atresia.
Now, small bowel atresias are physiologically different in their cause. How so?
Well, unlike DA, which is often an intrinsic failure of the bowel to recanalize during development, isolated small bowel atresias in the jejunum or ileum are usually caused by localized vascular accidents that happen after organogenesis is already complete.
Like a volvulus.
Exactly, like a segmental volvulus or an intussusception that compromises the blood flow to a segment of bowel.
This presents a huge surgical challenge because of the different sizes of the bowel segments.
It creates a massive discrepancy. The proximal upstream bowel is massively dilated and dismodal because it's been obstructed for months. And the distal downstream bowel is this tiny, narrow microcolon because it's never been used.
So what's the approach?
You have to resect the hugely dilated, unhealthy segment, but you have to be extremely careful not to sacrifice too much length. A primary anastomosis is preferred, but the source notes that you can't attempt to connect segments with a size difference greater than about 5:1.
And if the difference is too vast?
Then you have to do a staged repair using a temporary stoma and a mucus fistula to decompress that proximal bowel before you try to connect it later.
Let's move to the acute emergency that causes these vascular accidents. Malrotation and volvulus. Our anchor here is the loose anchor mesentery.
That is the perfect image for this. Normal development involves this complex 270-degree rotation of the gut, which ultimately fixes the mesentery down with a broad, stable base, a stable anchor.
But in malrotation, that doesn't happen.
In malrotation, that rotation is incomplete. The small bowel mesentery has a very narrow, unstable base, often just confined to the stalk of the superior mesenteric artery.
The loose anchor.
The loose anchor.
Yeah.
And that allows the entire midgut to twist freely around the SMA, a midgut volvulus.
How do we differentiate the presentations? This seems critical.
Well, acute volvulus, where the twisting compromises that SMA blood supply, is what we call the surgical apocalypse. It presents with green, bilious vomiting.
Which is always a red flag.
It's obstruction, and critically, it's a sign of impending vascular compromise. You have to treat that as ischemia until you prove otherwise. A chronic volvulus is much more subtle. Failure to thrive, cholecystitis, maybe a protein-losing enteropathy.
So for the acute acidotic baby with bilious vomiting and a gasless abdomen, what's the protocol?
Immediate laparotomy. There is no time for lengthy imaging. You open the abdomen to untwist the volvulus and assess the viability of the bowel.
And for the well baby, where the diagnosis is less acute?
For the well baby, you perform a contrast study. Normal, stable anatomy requires the duodenal jejunal flexure to be located to the left of the vertebral column at the level of the pylorus. If it's displaced, that confirms malrotation.
And the surgical fix for this?
The LADS procedure. You untwist the gut, you divide any fibrous bands, GLADS bands, that might be obstructing the duodenum, and then you surgically broaden the mesentery to fix the bowel in the non-rotated position.
Which is?
Duodenum and small bowel on the right, colon on the left. And you also remove the appendix during this procedure because its location is no longer predictable.
Okay, time for a fictional case study check-in on this emergency.
Let's do it.
A 3-day-old full-term baby is brought in with escalating bile-stained vomiting and abdominal distension. An X-ray shows gas distributed throughout the small intestine, but there is definitely no double bubble sign. You suspect obstruction. Why does the absence of the double bubble move your suspicion away from duodenal atresia? What is the most critical emergency you must rule out, and what operation stabilizes the mesentery?
The absence of the double bubble suggests the obstruction is distal to the duodenum, likely jejunum or ileum. The critical emergency is midgut volvulus, and it's stabilized by Ladd's procedure.
Next, we cover two separate but related entities, meconium ileus and necrotizing enteral colitis, NEC. Let's start with meconium ileus.
Meconium ileus is a functional obstruction almost always in the distal ileum, and it's caused by abnormally thick, inspissated meconium. It's just too sticky and dry to pass.
And this is highly specific for cystic fibrosis.
It's nearly pathognomonic for CFTR gene defects, yes.
This impacted meconium can lead to complications.
It creates a pressure point. It can cause a segmental volvulus, which leads to the atresias we just discussed, or it can cause a perforation.
What are the radiological signs?
Antenatal perforation results in characteristic peritoneal calcification you can see on X-ray. Postnatally, the obstruction shows up on an abdominal X-ray with a ground glass appearance, which is due to small bubbles mixed within that thick meconium.
How is the management stratified here?
Simple meconium ileus, so without perforation or volvulus, can often be managed non-surgically if the baby is well hydrated.
With an enema?
Yes. You use a water-soluble hyperosmolar contrast enema, like diatrizoate, under fluoroscopy. The contrast pulls fluid into the bowel lumen and effectively dissolves the meconium plug. It also gives you the diagnostic finding of a microcolon, confirming the distal bowel hasn't been used.
And complicated cases.
Complicated cases require a laparotomy for a manual luminal washout, and often a temporary stoma. Postoperatively, N-acetylcysteine is crucial to help loosen any residual meconium.
Now, for the most feared acquired condition, necrotizing enteral colitis, NEC.
NEC is the great acquired catastrophe of the NICU. It's a patchy, hemorrhagic, and sometimes gangrenous inflammation of the bowel wall.
Who gets it?
It's seen in about 10% of premature fed babies, typically appearing a few days after birth. It commonly targets the terminal ileum and the colon, and critically, the source notes it is significantly less common in breastfed babies.
How does the progression escalate from mild to surgical?
Well, mild NAC, what we call Bell stage ISO, feed intolerance, bilious aspirates, mild distension, is usually managed conservatively.
Feeding gut rest and antibiotics.
Complete gut rest, gastric decompression, broad-spectrum antibiotics, and parenteral nutrition, or PN.
But the shift to surgical intervention can be incredibly rapid. What are the definitive thresholds?
Surgical necessity, or Bell stage 3, is triggered by clear clinical deterioration. So, severe abdominal tenderness, systemic sepsis, multi-organ failure requiring ventilation or inotropes, or clear radiological signs of perforation.
What are those key radiological hallmarks that scream surgical emergency?
First, pneumatosis intestinalis. That's gas bubbles visible within the actual wall of the bowel, indicating bacterial invasion. Second, you might see gas in the portal vein.
And the most definitive sign?
The most definitive is pneumoperitoneum, which is free air in the abdomen, and that signifies a bowel perforation. These sickest babies progress rapidly, often showing abdominal discoloration, and they face a mortality rate approaching 30%.
Let's discuss the surgical options, including the role of damage control in this specific context.
Standard options involve a laparotomy, removing the dead or perforated segment, and then either a primary anastomosis or, more commonly, creating a defunctioning stoma.
But for the most unstable babies?
For the most unstable, critically ill babies, we use extreme damage control. The dead intestine is quickly resected, the ends are closed with clips, we call it the clip and drop technique, and the entire abdomen is left open.
A laparostomy.
Laparostomy, covered in the vacuum dressing. This allows us to decompress the abdomen and stabilize the physiology before we even think about attempting a definitive repair days later.
The prognosis, as you mentioned, really depends on how much bowel is left.
It does. Those with less than 40 centimeters of remaining small intestine risk long-term short bowel syndrome and often require prolonged parenteral nutrition.
We shift now to biliary atresia and anorectal Hirschsprung's disease, starting with biliary atresia, an issue of plumbing and persistence.
Biliary atresia is a progressive, obliterative cholangiopathy, which is a fancy way of saying the bile ducts are progressively narrowed and destroyed. It can be congenital or acquired, sometimes linked to CMV infection.
And the majority are type 3.
Yes, 80% affect the proximal bile ducts.
The presentation is often insidious, but it's critical to catch it early.
The key clinical presentation is conjugated hyperbilirubinemia, along with pale, acolic stools and dark urine, usually in the first few weeks of life. Catching this early is everything because a delayed presentation allows for progressive, irreversible liver fibrosis.
And the gold standard surgical management is the Kasai procedure.
The Kasai hepatical portoenterostomy. It's an intricate operation where you dissect the small fibrosed bile duct remnants in the porta hepatis and then anastomose a Roux-en-Y loop of jejunum directly to that exposed portal plate.
But it's not always a permanent fix.
It's not. The source emphasizes that many children, despite an initially successful Kasai, will ultimately require a liver transplant later in life.
Okay, let's move to anorectal malformations, ARM. The difference in presentation between sexes seems to dictate the entire care pathway.
This is a vital diagnostic point. In boys, the most common presentation is that there's simply no opening at the perineum, or the rectum fistulates to the urethra, prostate, or bladder neck.
But in girls, it's often missed initially.
It is because they do pass meconium. It's just coming out of an abnormal opening, usually a rectoperineal or a rectovestibular fistula.
And the most complex version in girls.
The cloaca, where the rectum, vagina, and urethra all join into a single common channel.
So can you outline the staged management required for these complex fistulae?
For complex fistulae, management is staged over many months. Stage 1 is creating a proximal divided colostomy. This allows for decompression and nutrition while protecting the perineum from infection.
And the definitive repair.
Stage 2, the definitive repair, often requires a posterior sagittal anorectoplasty, or PSARP. This is done through a midline incision, guided by a nerve stimulator to find the sphincter complex. But before that, a contrast study through the stoma is essential to map out the fistula. The stoma closure is the third stage.
Our final GI topic, Hirschsprung's disease. The traffic jam colon is our anchor for this functional obstruction.
That phrase perfectly captures the physiology. The etiology is a neurocrestopathy, which means there was a failure of the critical neural crest cells to migrate fully down the GI tract during development.
Often linked to genetic defects.
Yes, notably in the RET proto-oncogene. The resulting pathology is ganglionosis, the complete absence of ganglion cells or nerves in the distal bowel segment.
And what happens mechanically when those nerves are absent?
The smooth muscle in that segment is permanently contracted because it lacks the inhibitory nerves it needs to relax. This creates a functional obstruction, a perpetual traffic jam at the end of the line.
Where is this failure most commonly seen?
About 75% of cases are confined to the rectosigmoid segment. The ganglionic segment is narrow, and the proximal, normally innervated bowel dilates dramatically, trying to push past it. This creates the diagnostic transition zone.
Clinically, what sets this diagnosis in motion?
Delayed passage of meconium beyond the first 48 hours, abdominal distension, and often bilious vomiting.
And the diagnosis?
Initial management is stabilization, aggressive gastric decompression, antibiotics, and critical bowel washouts. The definitive diagnosis relies on a cot-side suction rectal biopsy, which confirms the absence of ganglion cells.
And the definitive surgical correction.
A contrast enema might show that classic narrow ganglionic segment and the dilated proximal bowel. If the initial decompression fails, a stoma is fashioned. Definitive surgery, the pull-through procedures, remove the ganglionic segment and bring the normal innervated bowel down to the anus.
But that's not the end of the story.
Not at all. The source strongly emphasizes the necessity of lifelong colorectal follow-up for chronic constipation or incontinence.
We have dissected the GI tract failures. Now let's transition to section 3, abdominal wall and thoracic defects. And we can use a really powerful dichotomy here, the open versus covered defect distinction, to anchor the differences between gastroschisis and exomphalos.
This contrast is crucial. The etiologies, the associated anomalies, and the immediate management are completely different.
Okay, let's start with gastroschisis, the open defect.
Right. Gastroschisis is a full-thickness defect of the abdominal wall, located almost always to the right side of the umbilical cord. The viscera, intestines, stomach, sometimes gonads, are entirely exposed.
And the etiology is typically environmental.
Yes, associated with young maternal age and exposures like smoking or recreational drugs.
What makes this so dangerous besides just the exposure?
Well, because the defect is small, it creates a high risk of intestinal damage in utero. The defect can narrow, we call it closing gastroschisis, which compresses the mesenteric blood supply of the exposed loops.
So you end up with atresias.
A high incidence of intestinal atresias, yes. And the bowel itself is often thickened, matted, and inflamed from constant exposure to amniotic fluid.
So what's the delicate initial care protocol?
Immediate priorities are preventing aspiration and minimizing fluid loss. The exposed viscera are gently placed into a sterile, transparent plastic bag or even just specialized plastic wrap to minimize evaporative loss, which is massive.
And fluids.
A large bore NG tube for decompression and aggressive fluid resuscitation is absolutely required.
And the surgical strategies.
The goal is closure. If the abdomen is spacious, you could do a primary closure. But if the abdominal cavity is too small to contain the bowel without risking abdominal compartment syndrome, a silo is constructed.
What's a silo?
It's a temporary structure made of flexible silastic sheeting. This silo allows the bowel to be gradually manually reduced at the bedside over several days. And because of the inflamed state of the bowel, prolonged PN, often 4 weeks or more, is always necessary.
Now, in stark contrast, we have exomphalos, the covered defect.
Exomphalos is a central defect where the prolapsed viscera are covered by a thin, protective, 3-layered membrane that's continuous with the umbilical cord.
And critically, the etiology here is highly genetic and developmental.
Absolutely. This defect has a very high association with genetic disorders, particularly aneuploidies like trisomy 18 and 13, and overgrowth syndromes like Beckwith-Wiedemann syndrome. Cardiac defects are also very common.
So screening is mandatory again.
Genetic screening and aggressive echocardiography are mandatory, yes.
How does the presence of the liver change the management?
Exomphalos minor, so a small defect with no liver involvement, is generally repaired primarily. But exomphalos major, where the sac contains the liver, demands a staged approach.
Why?
Because attempting an early closure risks deadly abdominal compartment syndrome. The preferred stage technique involves painting the sac with topical antibacterial agents like manuka honey or silver sulfidazine to stimulate skin growth over the sac. This creates a durable scar, and the resulting large ventral hernia is repaired months or even years later.
Shifting to thoracic surgery, let's dive into congenital diaphragmatic hernia, CDH, a pathology of space and pressure.
CDH is a defect in the diaphragm, allowing abdominal contents to herniate into the chest. The most common is the left posterolateral defect, the Bach-Deleck hernia.
And the pathology is twofold.
It is. It's structural because of the herniation, but more importantly, it's a failure of lung development, lung hypoplasia, which is partly mechanical compression, but also partly an intrinsic genetic failure.
The ultimate prognosis often relies on antenatal findings.
Yes, the severity is predicted prenatally using the observed to expected lung head ratio and the total fetal lung volume measured by ultrasound and MRI. These give you critical prognostic information.
Now, for the most critical management distinction, which separates CDH from every other hernia we've discussed.
You must remember this. Urgently reducing the herniated bowel back into the abdomen does not improve gas exchange in CDH.
So what is the priority?
The underlying problem is not the bowel's location. It's the hypoplastic, diseased lung and the dangerously high pulmonary pressures. The absolute priority is stabilizing the pulmonary circulation and managing that pulmonary hypertension.
How do you achieve that?
Aggressive pulmonary management. We intubate immediately, relax the muscles, and use extremely gentle ventilation strategies. Often permissive hypercapnia, meaning we let the CO2 rise slightly, and high-frequency oscillation, all to avoid damaging the fragile lung tissue.
And you treat the hypertension directly.
With pulmonary vasodilators like inhaled nitric oxide, prostaglandin E1, and sometimes milrinone and inotropes. If it's refractory, the baby requires referral for extracorporeal life support, or ECLS.
Only once the pulmonary circulation has stabilized do you consider surgical repair.
Correct. The operation is offered once the baby can tolerate it. Large defects often require a patch silastic or G-Ortex to close the hole.
Finally, in the thorax, we have congenital pulmonary airway malformations, CPAMs.
This is an umbrella term for 3 groups: congenital cystic adenomatoid malformations, CCAMs, bronchopulmonary sequestrations, BPSs, and congenital lobar emphysema, CLE.
The defining characteristic of a sequestration is its blood supply.
Exactly. A BPS has an aberrant arterial blood supply, usually arising directly from the aorta rather than the pulmonary artery.
When is excision necessary?
If the malformation causes mass effect or compromise at birth, it requires immediate excision. But if the baby is asymptomatic, the source suggests that cross-sectional CT imaging to define the exact anatomy and vasculature can often be safely delayed for several months.
We've covered structural failures, but the chapter also briefly addresses newborn tumors and the vital long-term relevance of this field. We need to expand this section a bit to provide the necessary depth.
Let's focus on 2 high-yield tumors. First, the sacrococcygeal teratoma, SCT. This is the most common germ cell tumor in infancy, arising from the coccyx. Most are diagnosed antenatally.
While most are benign, what makes these tumors dangerous in utero, and what is the critical surgical step for excision?
Very large SCTs can dangerously shunt blood away from the fetus, causing a high output state that risks fetal heart failure. The surgical requirement is absolute. Complete excision must include removal of the coccyx,
Why is that so important?
because malignant germ cell nests often reside in the coccygeal bone. The pulpa floor is then reconstructed. And postoperatively, these children need long-term monitoring of fetoprotein levels, as a rise is the earliest indicator of recurrence.
And the key renal tumor?
The congenital mesoblastic nephroma, CMN. This presents as a large, often palpable, solid renal mass. The critical clinical nugget here is that CMNs can cause paraneoplastic syndromes.
Let's elaborate on that mechanism. Why do they cause hypertension and hypercalcemia?
The tumor cells themselves can secrete biologically active substances. They can produce renin, which drives the renin-angiotensin-aldosterone system into overdrive, leading to hypertension.
And the high calcium?
They can also secrete prostaglandins, which increase calcium reabsorption from bone or the kidney, resulting in hypercalcemia. A nephrorectomy is usually curative.
That brings us to our final and perhaps most important section for the broader medical audience. Why adult surgeons need an overview, the lifelong impact. Why does a general surgeon need to understand this neonatal chapter?
Because neonatal surgery is the beginning of a lifelong journey for these patients. These conditions don't just vanish. Rarely, primary defects like malrotation or CDH can present for the very first time in adulthood.
But the more common scenario is managing the adult survivor.
Exactly. Every adult who survived neonatal surgery will present with either related pathology or an incidental condition that their complex history influences. Survivors of anorectal malformations or Hirschsprung's disease face a lifelong risk of chronic functional issues.
Constipation, incontinence.
Yes, and they require dedicated colorectal follow-up for motility management.
And what about the specialized female survivors?
Girls who survived complex ARM, especially cloaca, require highly specialized gynecological and obstetric care throughout their lives. Their unique, reconstructed anatomy requires proactive management for puberty, pregnancy, and delivery.
And what follow-up is necessary for the ODF survivors we discussed earlier?
They need upper gastrointestinal surgical follow-up. They're prone to chronic issues like strictures at the anastomosis site, which might need repeat dilation, and severe gastroesophageal reflux, or GERD. This can lead to Barrett's metaplasia, or even malignancy later in life.
So their neonatal history directly dictates their adult screening needs.
It absolutely does. The knowledge in Chapter 18 is foundational for understanding future adult pathology.
That was a complete and comprehensive sweep through this dense surgical territory. We successfully built our core memory anchors: the extreme fragility of the house of cards for physiology, the communication failure for AF, the loose anchor mesentery for avulvulus, the acquired catastrophe of NEC, and the open versus covered distinction for abdominal wall defects.
Use this expanded framework to dive into the original text. You now know the critical why behind the what. This field demands balancing highly intricate surgical repairs with the extreme instability of the patient's physiology. By anchoring these concepts, the complexity becomes much more manageable.
And finally, a provocative thought for you to mull over after this deep dive. Considering the extreme fragility and high risk of intraventricular hemorrhage in the preterm infant, an issue highly sensitive to osmotic and hemodynamic shifts, what cascading long-term neurological and neurodevelopmental consequences might arise if perioperative temperature and fluid management protocols are deviated from, even slightly.
Think about the lasting legacy of managing that initial volatile environment.
We'll leave you with that.